Hello and welcome to the second session on the International AIDS Society, that's the IAS 2023 update. My name is Oche Agbaji. I'm a professor of nephrology and HIV medicine at the University of Jos and Jos University Teaching Hospital. And with me to look at these updates and discuss together, I have my colleague, Professor Sulaimon Akomu, who is a professor of hematology and transfusion medicine from the Lagos University Teaching Hospital and the College of Medicine, University of Lagos. Prof, you are welcome.
Thank you very much, my brother.
Thank you. So we'll be going on to look at the second part of this update, and we'll be looking now at high rates of long-term HIV RNA suppression after virologic failure in the advanced trial. Prof, so is this something that you have seen in your practice, that patients on treatment after failing can resuppress?
Yes, but it depends on the way we define the failure. The one we are familiar with is the one we describe as viral blips.
Yes.
Just a little short hop of a viral load after a period of viral suppression. So the viral load becomes detectable.
Okay.
But usually not too high. I'll find that the count is now above 1,000, and maybe 400, 500, and on its own without having to switch therapy, the viral load can become resuppressed. But the phenomenon I hope you are trying to preach today is a situation where, depending on availability of very potent antiviral therapy like Integrapha, I think it's advisable that one may not rush, to switch therapy, as maybe for some very good properties of those drugs. There's still a chance that individual might resuppress. What data is available, I think, if you review the data with us, you might be able to find some information that will support that position.
Yes, you are correct. So Dr. Bosch and colleagues presented at the just concluded IAS at Brisbane, and we'll look at some data from there. So it's known that we have over 24 million people now worldwide that are taking antiretroviral therapy. And the WHO guidelines has defined virologic failure or treatment failure in relation to viral RNA suppression. And if there's RNA suppression, that is the threshold of 1,000 copies per mil. If it's higher than that, WHO defines that as a treatment failure. But it's also been found that you cannot say someone has treatment failure just by one viral load that is above 1,000 copies. So you now have to take the patient through enhanced adherence counseling for 3 months and then repeat that HIV viral load again, or HIV RNA level. And it's only when it remains above 1,000 copies that it's defined as a treatment failure. So in the advanced trial, what they did was to compare two regimens, those that were on dolutegravir-based regimen and then efavirenz-based regimen, and followed them up to determine which one of these people developed or resuppressed after a time of high viral load. So essentially, the inclusion criteria for the advanced trial was that the patient had to be HIV naive, treatment naive, HIV positive, treatment naive, and the viral RNA has to be above 500 copies per mil. Those that had tuberculosis or were pregnant were excluded from the trial. And this study, there was no baseline genotyping. So Over 1,000 patients were recruited into the study, and they were randomized in 3 arms according to the regimens. So one arm had a tenofovir alafenamide, which is a brand of, a type of tenofovir with emtricitabine and then dolutegravir, about 351. And the second arm had tenofovir disoproxyl fumarate, which is the common tenofovir called TDS, with emtricitabine and dolutegravir, also 351 participants in that arm. And then the last part had TDF with emtricitabine and efavirenz. Again,
That's very unique. Every
yes,
group is 351, 351,
yes.
351.
So they had 351, 351. And then they had baseline visits, and RNA levels were done at each of the visits from month 1 to baseline month 4 or week 4, week 12, 24, all the way to 192 weeks.
That's a long time follow-up.
Yes. So they were followed for about 192 weeks. And in terms of baseline characteristics and initial RNA suppression, it was similar between the 3 arms of the study. And about 95% of people that had HIV RNA elevations above 1,000 copies showed resuppression below 50 copies.
95%.
Yes, after 48 weeks with adherence counseling for those that were on the dolutegravir-based arm. So that was something that
That's very
really came.
significant.
Yes, and you can see this. It's obvious from the slide that we have there. So essentially, our take home here is in terms of viral suppression. For those, in terms of viremia above 1,000 copies, both arms, we had similar results, isn't it? All of them were above 1,000, those that were recruited. However, HIV RNA resuppression, and this is the main take home here, was significantly more likely for those that were taking DTG, whether it was with TAF or with TDF. This is a strong take home here. So these results, actually, what they are saying is, if we see HIV viral RNA above 1,000 copies, we should not be in a hurry to switch those patients off DTG. Switch to second line for those that are on a DTG containing regimen. So, of course, in this, one of the limitations was we didn't do baseline genotyping. And there was also, they didn't do baseline genotyping, and there was no resistance that was observed at all against the dolutegravir. So what do you see being on one of the policy-making bodies and actually heading it in Nigeria? What do you think will be your advice
The
for
first
people that
thing
are on
that came to
DTG?
my mind is that I want to agree with the trialist finding because of what I understand about the property of that drug called DTG.
Yes.
Of all the instays that we have, DTG is known to complex irreversibly with the integrase enzyme.
Yes.
Unlike the other drugs that may compress with the integrase enzyme and can dissociate, but when DTG binds, it binds very avidly, doesn't dissociate.
Okay.
And one other property about DTG is that even if the integrase enzyme has accumulated a number of mutations, the drug is still capable of binding and inhibiting the integrase enzyme. So the fact that the people have virally failed, and we still see them resuppressing, maybe as a result of that very important property of DTG, its capacity, avidity to bind irreversibly. So I think program-wise, this is very instructive. And when we are drawing the national treatment guidelines for those that are on DTG-based regimen, we've got to take some cautions on what to advise in our guideline, when and how not to so soon switch those that we see. are failing DTG-containing regimen. I think it's very instructive.
Yes.
Thank you for
Thank
sharing
you.
this data.
Thank you. That is the finding by Dr. Bosch and his colleagues, and they presented it. And I think another important take home is if someone has been found to fail DTG, they are also recommending that it is important that we do HIV-resistant testing to determine the way forward.
And for information of people who are practicing in Nigeria, NIMA has a little support from Thermo Fisher and to study DTG related resistant mutations among Nigerians that are on DTG. And so if you are out there and your patient on DTG appears to be failing regimen, if you can actually shift the sample of these patients, to NIMA, there's a small grant now running in NIMA to look at the resistant pattern on those who are failing DTG-containing regimen.
Thank you very much, Prof. That's good information.
You're welcome.
Thank you very much.